switch our mobile phone off or even silent, please.
Thank you very much for the kind introduction. It's a pleasure for me to talk about the treatment of depression. One of the things that we have to face when we're treating depression is the fact that it's a multi-stage treatment, in the sense that when we treat a patient with depression, we want to first get the patient to respond to treatment. But typically that's not enough. We have to really continue our treatment in what we call continuation phase. And that's where the challenge. About 25% of patients treated with depression will actually not continue the treatment. And we know that if you stop the treatment earlier, your chances of relapse are quite high. So the standard therapy in depression is typically an acute phase where we're trying to get the patient better. And if we're successful, we continue that treatment for 4 to 6 months. And then there's a decision, typically, do I discontinue the antidepressant at that point, or do I continue further? And usually that decision is influenced by the course of the illness, the history of the patient. I remember years ago, I treated a colleague, professor of medicine in Boston, and it was his first depressive episode. And he got better, and at the end of the 6 months of continuation therapy, we discussed the fact that he had no prior episodes, he was in his 40s, very good psychosocial support, levels of stress that were relatively modest. And so we decided to discontinue treatment. And about 9 months later, he had a recurrence of the depression. He came back to me and he said, Dr. Fava, how could you let me stop the medicine if you knew that this could happen? So often we're faced with the challenge of making decisions in the long-term treatment of depression. When we're treating patients with antidepressant therapies, we have different degrees of response. There are patients who don't respond at all, for whom the level of improvement is minimal or not at all. We have what we call the partial responders, those who have had some improvement, but they're still quite symptomatic. And then those who have had a much more robust level of improvement. Ideally, we try to aim for remission, for a point in which symptoms are pretty much abated, and the patient has returned to prior level of function. We typically have 5 approaches to the treatment of depression. One is with psychosocial therapies. In particular, we're going to talk about CBT and IPT. We have pharmacological therapies that are quite well established. And we have somatic therapies. Then we have the more novel investigational treatments that are not yet approved. And finally, the alternative and natural therapies. So, talking therapies are quite commonly used for the treatment of depression. And at least in the United States, we have a great variety of forms of therapies. Psychodynamics, supportive. The ones that probably have the best evidence for the treatment of depression are cognitive behavioral therapy, CBT, and interpersonal therapy, or IPT. We also have what we call integrated therapy that tries to combine different techniques. In terms of pharmacological therapies, these are probably by far the most popular therapies. I would say both in North America and Europe, and I suspect in the Middle East as well. And those are the SSRIs, selective serotonin reuptake inhibitors. We have serotonin norepinephrine reuptake inhibitors that block not only the serotonin transporter but also the norepinephrine transporter. We have typical antidepressants that don't quite fit either kind of category. And then we have the older treatments, the tricyclics and the MAO inhibitors. For somatic therapies, light therapies has quite established efficacy for seasonal affective disorder. ECT by far the most effective somatic therapy that we have, though there are obviously challenges in terms of side effect profile. There's some data on anterior cingulotomy as a form of psychosurgery that has been used for very rare extraordinary refractory cases. Vagal nerve stimulation, which is approved in the U.S. for the treatment of depression. And then we have transcranial magnetic stimulation, deep brain stimulation, low field magnetic stimulation, and near-infrared radiation. Our group actually is pioneering the development of the low field magnetic stimulation, which is a form of kind of brain stimulation that is very safe and doesn't quite require the complexity of the transcranial magnetic stimulation. And we're conducting the first controlled study in the world in the treatment of depression with this machine. We're also conducting a study, we're starting to conduct a study on TMS as well. With respect to alternative and natural remedies, by the way, do you have St. John's wort at Caricom? Is it available in Kuwait? It is. And who can prescribe St. John's wort? Is it over the counter or you need a prescription?
Over the counter.
Over the counter. Okay. How many people believe that St. John's wort works? Two people. Okay. Well, there are a lot of skeptics on St. John's wort. Mostly because two studies, one conducted by the NIH and one conducted by Pfizer Pharmaceuticals, did not show any evidence of the effect of St. John's wort. However, our group has actually conducted a study in which St. John's wort worked. In fact, it worked significantly better than Prozac and fluoxetine. And we published a paper in Journal of Clinical Psychopharmacology. However, despite our contribution, there is a lot of skepticism about St. John's wort. I think partly because there is great variability in the quality of the product depending on what you prescribe. It really depends on the crop of St. John's wort. Semi is S-acetylmethionine. It's over the counter in the United States. Is it available here? Okay. Omega-3 fatty acids. I'm assuming they're available here. Is that right? Yes. And those are quite promising. Our group has done studies on semi showing that it works in depression, and also omega-3 fatty acids, usually 1 gram a day of the combination of EPA and DHA. And our group has also studied acupuncture. For acupuncture, even though there are many patients that will swear by, we don't have adequate evidence for effectiveness. Now, when we treat depression, the first thing that we try to do in our group is to subtype the depression itself, try to understand what type of depression, whether it has typical features with oversleeping and overeating, or whether it's more melancholic or more anxious. And we try to kind of tailor the treatment to the type of depression. We also, in choosing the treatment, look at the side effect profile of the treatment and try to use a treatment that the patient feels most comfortable. And finally, efficacy is a factor. Although most for most agents that we use, there's no evidence that one is more efficacious than another. The SSRIs are probably the most widely used antidepressants in the United States and in Europe. They have a drug-drug interaction with monoamine oxidase inhibitors, and sometimes with drugs that are metabolized through the cytochrome P450 system. The side effects of the SSRIs were initially played down. People used to think that compared to the tricyclics, they were devoid of side effects. But in fact, the gastrointestinal symptoms are common side effects of SSRIs: insomnia and sleep disruption. About a third of depressed patients who are started on SSRIs will develop sexual dysfunction, and there are less common side effects like bruxism, the clenching of teeth at night, which is sometimes quite troublesome, increased risk of bleeding, and cognitive side effects, sometimes trouble with memory and with finding words. The SSRIs have a very similar side effect profile. The only difference, if you wish, compared to the SSRIs, is the fact that with venlafaxine you have to monitor the blood pressure, because with over 150 milligrams of venlafaxine can actually significantly raise blood pressure. And with the loxetine, Cymbalta, you have to monitor liver function in those who have pre-existing liver conditions. Now, bupropion, do you have bupropion or Butyrin here? Quick, yes, okay. What? It will come, it will arrive, let's see. Bupropion is it's a drug that has significantly less likelihood of causing sexual dysfunction. And while the SSRIs would cause weight gain in about 15 to 20% of the patients, bupropion is weight neutral. So in the United States, it's very popular among psychiatrists because of that improved side effect profile. On the other hand, bupropion can lower the seizure threshold, and so you cannot give more than 450 milligrams a day, and you have to use an extended release formulation to reduce the risk of seizures. The tricyclics, they're very effective antidepressants. I still use tricyclics in my practice, even though they have anticholinergic side effects like mouth, constipation, vertigo, because of orthostatic hypotension, because of one antagonism, they can cause sexual dysfunction. Weight gain with tricyclics can be, particularly tertiary tricyclics, can be quite significant. For that reason, I typically favor the secondary antitricyclics, the zipramine, nortriptyline, and protriptyline, which is my Vactor. What do we do when we treat a patient pharmacologically? So we first negotiate the treatment, try to educate the patient. Very important to tell patients that they're not going to get better right away when they start pharmacotherapy. We initiate the treatment and monitor the response. And then we see if the patient has a response or recovers from the episode. We continue the therapy. If there is partial improvement, we may kind of continue the treatment and adjust it. And then if there are side effects, we either manage the side effects or we may end up switching. And then if there are no side effects, we may increase the dose and optimize the therapy. When do we declare a trial ineffective? When do we decide that pharmacological treatment that we've initiated is not working? Typically, we make that declaration after 6 or 8 or 12 weeks. The problem, though, is that sometimes patients don't feel that they can really wait 12 weeks for you to tell them that the treatment is not working. And so, at least in the United States, the idea of augmentation, the combination become very popular because of that pressure to make decisions about whether the treatment should continue or not. Now, antidepressants are not, unfortunately, that effective. This is the largest study ever conducted in depression. This is STAR-D. I had the pleasure of being the co-principal investigator with John Rush of this study. That really, in some ways, changed the way we practice in North America psychopharmacology of depression. Because what we kind of saw in the study, which involved the recruitment of over 4,000 patients with depression, what we found is that even when you optimize the treatment, these are the results of level 1 of STAR-D, when patients are treated for a minimum of 8 weeks, a minimum dose of 40 milligrams of citalopram, so an adequate dose, adequate duration. This is the average treatment in level 1. Only a third of the patients achieve remission. And so then we have to make a decision. What are we going to do? The first thing that we in practice consider is switching. And we do that particularly when patients don't respond at all, or when they respond but they have partially and have side effects, or when they clearly can't tolerate the treatment. There are 2 types of switches. One is within the class, so you go from one SSRI to another SSRI, or from one SNRI to another SNRI, or tricyclic, or switching from one class to another. Many researchers, including myself, feel that ultimately all the antidepressants that are currently available are primarily monoamine-based therapies. Therefore, the differences between treatments is not that robust. However, for certain subtypes of depression, it might make more sense. So, for example, in atypical depression, oversleeping and overeating, monoamine inhibitors are very effective. So I may switch to an AOI, someone who's not responded to the SSRI, or in melancholic depression, probably the best treatment that we have pharmacologically is clomipramine, anaphylm. Do you have clomipramine here? Yes. And that's a very, very effective for melancholic depression. As you know from the DUET studies that show that in both studies, clomipramine was able to kind of beat citalopram and paroxetine in the treatment of melancholic depression. However, in STAR-D, when we looked at what happens if you don't respond to citalopram and you're switched to another SSRI, sertraline, or venlafaxine SSRI, or bupropion, the outcome was pretty similar. About 1/4 of the patients remitted, with no difference in treatment. And this results have challenged the view that you should go to a different class for all comers. In level 3 of STAR-D, we then tried to do another switch, and the remission rates then went down significantly. As you can see, only 1 in 10 patients remit if you keep trying antidepressants. So in North America, we basically recommend that you don't do a third switch, meaning you don't go from one antidepressant to another. One switch makes sense. 2 switches, the odds of remission are too low. And typically we switch either with the gradual tapering of the first drug and start on the second, it's called cross taper, or we do sometimes abrupt switches, where we stop the antidepressant and start the next one immediately. And we do that particularly when we switch within the class or from, let's say, an SSRI to an SNRI. The next approach that we use clinically is that of dose increase. When we do that, we basically push the dose of the antidepressant to a much higher level, sometimes even above the recommended dose of that agent. And the reason for doing that is that sometimes we want to get adequate levels of the antidepressant in ultra-rapid metabolizers, or to change a little bit the pharmacological action. For example, fluoxetine at lower doses is permitted as SSRI, at higher doses becomes a little bit of an SNRI. Sertraline at low doses is pretty much an SSRI, higher doses has an effect on dopamine reuptake inhibition. The first study that actually showed the benefit of raising the dose was a study that I conducted in the early 90s, and we replicated in a study that we completed in the late 90s and published in 2002. In those two studies with identical design, we took patients who were depressed, we treated them with fluoxetine, 20 milligrams a day for 8 weeks, and if they didn't respond, we randomized them to either 60 milligrams of fluoxetine, so triple dose, or adding low dose lithium or low dose dizipramine. And what we found was that raising the dose was better than low dose lithium and low dose dizipramine. Now, this was a very controversial study. I remember that when I published my first study in 1994, I had colleagues, eminent colleagues from other universities calling me and saying, "Moricio, that's impossible. You know, how can it be that just raising the dose of fluoxetine would be more effective than lithium augmentation or dizipramine augmentation?" But we replicated those findings in a larger study, and it appears that particularly for partial responders, but even for non-responders, raising the dose works. Now, one of the things that I've learned over the years is that a lot of that efficacy is driven by people who metabolize the drugs quite rapidly. In fact, I had a patient of mine that I was treating. She was the spouse of a colleague, and at a certain point, she had a little bit of a response with 300 milligrams of sertraline. She had a little bit more robust response with 500, and then she really responded very nicely with 800 milligrams of sertraline. So, and her husband called me, said, Dr. Fava, I've never seen anybody with 800 milligrams of sertraline. What are you doing to my wife? She's, is this a problem? So I said, look, she had no side effects and no response at 200. I raised it strongly ultra-rapid metabolizer. But anyway, since she was so worried about it, I obtained a blood level when she was at 100 milligrams of sertraline. And that's like 4 times the maximum recommended dose in the US. And I got the blood level, and the blood level was exactly in the middle of the therapeutic blood level for sertraline. So, one of the challenges is that blood levels are not always available, and now people are using pharmacogenetic methods, looking at polymorphism on the cytocopy from 50 system to predict who's going to be an ultra-rapid metabolism. But I still like the old-fashioned blood level method because it gives you an idea of how much really is in the system. How do we use the dose increase approach clinically? Well, I personally usually double the dose. Someone is not responding, not having side effects to a standard dose, I'll double it. If they don't have side effects and no response, I'll double it again. But I wait usually 4 weeks before the next dose adjustment. And of course, blood levels are quite informative. The next approach is augmentation. And that augmentation is the use of a non-antidepressant to boost the efficacy of the antidepressant itself. The rationale for augmentation is sometimes to get a different neurochemical effect, affecting other neurotransmitter systems other than the monoamine, and sometimes to broaden the therapeutic effect to get maybe a bit of an anti-anxiety effect, or to combine different mechanisms like presynaptic release with uptake inhibition. Lithium augmentation is the most popular worldwide augmentation, but despite a very nice meta-analysis by Bauer saying that the odds of response to lithium are 3 times those of placebo, our group has never been able to show robust effects of lithium augmentation. This is a study from my colleague Andy Nierenberg in our group, in which he showed no difference from placebo, augmenting or tripling. We've had better luck with thyroid augmentation, usually 25-50 micrograms of T3, and in fact, in STAR-D, when we compared lithium augmentation to thyroid augmentation, there was a clear advantage, though not statistically significant for most measures. But as you can see with the Pritzker, you see a nice difference between T3 and lithium, T3 being better than lithium. Buspire, our chief was known for a famous quote in the 1990s. Buspire, he said publicly that Buspire was everything we wanted to see in an anti-anxiety drug except efficacy. So this quote that became quite famous from Dr. Jerry Rosendale has actually in some ways been challenged by some data in depression where Buspire has found maybe a better niche in depression than anxiety. And we use actually Buspire augmentation in our clinic with some success. The next augmentation comes with the use of dopaminergic agents. The earlier augmentation strategies used drugs that were very cumbersome, pergolide, bromocriptine, were making patients very nauseated because of the dopamine effects. But the new D2, D3 agonists from Affexol or Pinerol that are primarily indicated for restless leg syndrome or for Parkinson's, they are tolerated much better, and they're used quite extensively by psychopharmacologists in North America. I'm assuming you do have Affexol on there? Now, this amphetamine is a compound Vyvanse that has shown efficacy in augmentation, the first stimulant to show an effect in control studies in depression. And even though, for decades in consultation with psychiatry, this was a very popular strategy, there's never been really evidence for its efficacy until recently. An alternate to or substitute for stimulants is modafinil, which is a dopaminergic inhibitor marketed as Provigil. There's in North America modafinil, which is Nuvigil. But we did a study of modafinil in partial responders with residual fatigue and sleepiness, and we found a significant effect of this compound. However, of all the augmentation strategies, the one that has the best documented efficacy is atypical antipsychotics. This is a study by moricio with olanzapine plus fluoxetine showing the superiority over each compound alone. This is a study by Rob Berman with aripiprazole, certified 5 to 15 milligrams as an augmentation with diapine. It's studied by Bauer, showing the effect at 150 and 300 milligrams compared to placebo, and risperidone as well. Now the problem, however, with the typical antipsychotics is their side effect profile. These drugs can cause metabolic syndrome and the risk of thyroid dyskinesia, and so they're typically used at the end of the algorithm. Although I have to say that despite the side effect profile, these drugs are extremely popular in the United States. I'm wondering how many people use atypical antipsychotics in resistant depression here in Cleveland? Of the treatments at the horizon, ribosol and a drug for ALS, basically a neurodegenerative disorder. There are preliminary data with its efficacy in depression. Lamotrigine, no good evidence that it works, even though it works very well in bipolar depression, it doesn't work well in unipolar. So pyramid, Tocomex, some evidence of efficacy. So if you ask me, and I kind of prepare this table for you to kind of say, here's, if you have to ask me, what's the evidence of the efficacy of this augmentation strategy, antipsychotics, clearly the most efficacious, and then modafinil, Spira, semi, methylfolate, T3. Combination therapies, and actually, let me mention this because we completed 2 studies, one with L-methylfolate and one with semi, and both studies showed a clear efficacy compared to placebo. So although you don't have semi here, I wonder if you have methylfolate. If you have methylfolate, the active form of folate, 15 milligrams a day, quite efficacious. Combination therapies, it's a concomitant use of 2 antidepressants together. The rationale there is really typically to get a different chemical effect or to combine it for a mechanism of action. The biggest proponent of combination therapy is Craig Nelson, who's a professor at the University of California, San Francisco. He showed in a proof of concept trial that if you combine fluoxetine and dosiprolene in melancholic patients, you have higher remission rates than either drug alone. We didn't show, or didn't find much of an effect of this combination therapy in our study of non-melancholic depression. And in fact, the study with atomoxetine is a norepinephrine inhibitor available in many countries for the treatment of ADHD. Atomoxetine added to antidepressants did not really work as an augmentation strategy. However, a post-hoc analysis that Fred Reimer from Utah did, he found that those with the polymorphism of the serotonin transporter, the SS kind of version of that gene, had a robust effect. So there may be some patient for which adding an norepinephrine inhibitor works. In study, when we looked at buspirone and bupropion, so either a combination of bupropion and an SSRI versus adding buspirone, we found pretty much comparable efficacy between the 2 strategies. The popular strategy, I know there are many people here who have trained or worked in Canada. Pierre Vier is the biggest fan of mirtazapine augmentation. In fact, he published a study out of Ottawa with mirtazapine augmentation. And we selected that in study as our level 4 strategy and compared that to monoamine oxidase inhibitors with no difference really between the 2 treatments. Trazodone, some efficacy as a combination strategy with SSRIs. But at the end of the day, if you really look at all the options that we have pharmacologically, we can never really give up on patients. We have to realize that there are many, many options, pharmacological, non-pharmacological, that we can use. I have a brother that is a professor in Italy, and he's a big psychotherapy proponent. So he usually starts everyone on CBT, and then he often tells them that, if they really don't do well, then they'll get a pharmacotherapy. Now I tend to do the opposite. I start people on medicines, and then I offer psychotherapy when they don't respond. But I think that a critical aspect in the clinical practice of psychopharmacology is the idea that you want to always convey a sense of hope and confidence that we have so many options. I just listed a few that touch you with the fact that you seem to never give up hope that the next thing is going to work. And most of the times you're right, but sometimes I get a little, demoralized. But the fact that you have that confidence, it means a lot to me. I think that being mindful, we have lots and lots of strategies. And unfortunately, the one thing that we don't have is a good indication of which strategy works best for whom. So, the next phase in psychopharmacological treatment will be really the personalized medicine approach, where based on certain characteristics of patients, whether clinical, biological, neurophysiological, neuroimaging, we're currently conducting the largest study ever done on biomarkers of depression. It's called EMBARK. It's a $28 million study, and we're conducting with the University of Texas, Southwestern, Columbia University, and University of Michigan. And we're using neurophysiology, looking at neuroimaging, we're looking at genetics and proteomics and metabolomics to develop a new algorithm that may help us decide what treatment works best for whom. However, until we have robust data, still it's a trial and error thing, where you can start with psychotherapy and then try pharmacotherapy later, or vice versa, or try different pharmacotherapy strategies. Flexibility is critical in initiating treatment. I never try to appear dogmatic. Well, I think you have to take this. But one thing that I try to do is to exploit a little bit the placebo effect, meaning you don't want to, if you present to a patient in a hyper-realistic fashion that, here's an antidepressant and only 1 or 2 patients will really get better with this. And I don't really think you're have a good chance, but we can try. If you use this approach, you're really in some ways diminishing expectations. So the best thing you can do is, you can propose different treatments, but whatever you decide to do, show confidence, show optimism. You don't want to oversell and say, oh, I'm absolutely sure you're going to respond, but try to kind of use a little bit of that therapeutic element. Treatment resistance, unfortunately, is common, and we clearly have lots of options: switching, increasing the dose, augmentation, combination, and again, flexibility, next step strategies will give you the biggest bang for your buck. Thank you very much.
Thank you, Dr. Fava, for your interesting presentation. And I think one of the important issues you have raised that hope. Patients with depression needs to feel hope that they will improve, they will recover from depression. I think it was a very interesting presentation. The floor is open for any question. We have 5 minutes.
Thank you very much, Dr. Fava.
Do we have a microphone?
Thank you very much, Dr. Fava, for this very important, interesting lecture.
My question is, we face in our clinical practice some different cases of depression. One of them is mixed unipolar depression, which is depressive disorder with anxiety. The second is mixed state of a bipolar disorder, depression and anxiety. In your opinion, what is the best approach to treat those situations?
Great question. So, great question. In fact, I published a study in 1997, the first study to show that anxious depression is less likely to respond to antidepressant therapies. And that study confirmed that with study that anxious depression is a tougher to treat form of depression. Well, what do we do in anxious depression? Personally, I can tell you that I like to use kind of broad action antidepressants. So my favorite antidepressant, I have to confess, is clomipramine, Afrinil. Very, very effective in anxious depression, partly because an Afrinil, even with 25-50 milligrams, has anti-panic effects, anti-anxiety effects. So very, very effective. And we did a study with Cymbalta, another SNRI, showing that it had very, very good effects on anxious depression. On the other hand, if you have someone who's having a partial response to an SSRI, it's hard to think of going or switching to clomipramine at that point. So I typically add an anti-anxiety drug. Now, the benzodiazepines are quite effective for anxious depression, and gabapentin and pregabalin. Now, I have a question. Do people use benzodiazepines in Kuwait for the treatment of anxiety and anxious depression? A lot. Okay. There is some controversy because in the UK there's a strong anti-benzodiazepine approach, and in North America there is much greater kind of enthusiasm for benzodiazepine use. So I was wondering, that's why I asked the question. For mixed but kind of states, then that's another very challenging population. And usually, I tend to favor the use of mood stabilizers alone versus mood stabilizers plus antidepressants, because the antidepressants may complicate the course of the illness. Thank you.
Thank you for the informative lecture. I have only one question. You mentioned in one of your slides that SNRI are superior than SSRI in some population. I would like to know on which population they are superior than SSRI.
The SNRIs are superior to SSRIs. That's it. As I just mentioned that in all comers you don't really see a difference. In fact, when you look at the data comparing Cymbalta velocity versus SSRIs or venlafaxine, the difference is very, very small in efficacy. On the other hand, if you look at anxious depression, there may be an advantage of the SNRIs, and in melancholic depression, which is consistent with the DUET studies. So not in all comers, but maybe in some populations there may be a slight advantage.
Thank you, sir, for the lecture. It's a privilege to have such a beautiful lecture. My question is, we are currently giving our children amphetamine. We are giving benzodiazepine to our patients, our adult patients. We're now trying ketamine. Don't you think it's about time to relieve the pressure against THC and try to look for evidence about therapeutic?
Look to the effect of marijuana?
Of THC, not marijuana.
Okay. Yes. Well, I understand that you're saying, well, if we're using therapeutically drugs that have potential for abuse, such as amphetamines, benzodiazepines, why has there been very little research on THC depression? It's very interesting. I was talking with an anesthesiologist, a neuroscientist in Mass General. His name is Emery Brown. And he was telling me that he does very interesting research on how the brain looks like when you're getting an anesthetic. To look at the brain activity. And he has basically found that based on how you respond, you can almost tell the age of the person. That the brain reacts to the anesthetic propofol in a way that tells you how old you are, how old the brain is. And so he clearly sees if someone is 20, 40, 60, 80. And he had told me that, this was an anecdotal report from him, that he was studying the brain of a young man in his 20s, and suddenly he saw that the response was the response of an 80-year-old man. And so he asked this person, because this was a healthy volunteer, it's not so healthy, but anyway, it was supposed to be healthy volunteers, and do you do anything? Do you take any medicines? And he said, well, look, I smoke marijuana every day. And so he was telling me that he thinks that even though there's a lot of the safety, if you wish, of marijuana may have been overplayed, there may be some significant toxicity. There is toxicity also to some extent in the stimulants, ketamine, but THC, I think, is